of this ongoing series. And today we all have our guest speaker, Dr. Akshay Nair, with us. And we also have our two speakers, Dr. Gunjan, who's going to talk to us about
Good morning and a
anesthesia,
warm welcome
and Dr.
for the
Milind, who will
third
be
and the
informing us
last
about all
webinar
the
of this
complications
ongoing
which arise
series.
in the DCR
And
surgery.
today
And I think
we
Akshay is
all
going to
have
talk
our
on
guest
the
speaker,
field DCR
Dr. Akshay
cases.
Nair, with
So, with these welcome words, and next we will be meeting on 25th of August for the hands-on cadaveric workshop at IGGMC. Since we have our President, Dr. Thorat, with us, I request Sir to say a few words and then can hand over the mic to Preeti for the introductions.
Thank you, Shivani. On behalf of Vidarbha Ophthalmic Society, I welcome you all, and I really thank all judges, all panelists, and all speakers and moderators for sparing their valuable time. I really thank a team of Oculoplasty surgeon of Vidarbha uh, for their wonderful work, and they are working very hard to make it a grand success. And I'm sure at the end of hands-on work, everybody will be confident in doing DCRs. And even if sometimes we fail, Dr. Akshay sir is there to guide us regarding the failed DCRs. So again, I thank you everybody for their immense contributions. Thank you. And I'll pass on this info. Shivani.
Preeti, if you can introduce the speakers and the panelists.
Yes, ma'am. Is my screen visible?
Not yet.
Now, is it? Stop share करूं? Yeah. Okay. Double click. हाँ, yes. कहाँ पे?
It's okay. Now it's.
Sorry. Yes, now you can see. No, yeah. Yes, again from my side, I'll welcome everyone on this third day of DCA workshop. We have this pre-workshop webinar. So our panelists today are Dr. Shivani Sule ma'am, Dr. Shamik Mukadam sir, and Dr. Swapnil Patil sir. I'll give a brief introduction. Our beloved Dr. Shivani Sule ma'am, she is highly accomplished consultant, cataract and ophthalmic plastic surgeon. Presently, she is practicing at Sai Eye Hospital at Nagpur. And she has done her fellowship in ophthalmic plastic surgery from prestigious LV Prasad Institute, Hyderabad. And she not only she is a leader in her field, but she is also a very active contributor to the community. She has served in many clubs like Rotary Club at Nagpur. And beyond her professional commitments, she is a multifaceted individual. She is a proud member of the musical group Hum 3 Acoustic, passionate cricketer, and specifically she's a spin bowler, plus she's a marathon runner and a cyclist. And she's a and actually this is a seriously very good thing. She has also acted in Marathi dramas and short films. This shows her versatility, and her two daughters, Sharvari and Shomira, shows like one is a basketball player and another is a financial analyst at Bangalore. We welcome you, ma'am. And our second panelist is Dr. Shamik Mukadam sir. He is again a vitreoretinal surgeon, presently practicing at Anjani Eye Hospital, Nagpur. He has done his MBBS from Sawangi, and all his fellowships one of his fellowship is from Arvind Eye Hospital, another is from Lions Eye Institute, Perth, Australia, and he has been a great contributor to our as a scientific committee chairman of Vidarbha Ophthalmic Society. We welcome you, sir. And our third panelist is Dr. Swapnil Patil, sir. He is a dedicated and highly skilled ophthalmologist from, he's working as a director of Bhakti Netralaya, Malkapur district, Buldana, and he is committed to oculoplasty and ocular oncology services. He wants these services to his hometown and surrounding area of Jalgaon, Akola, and Bhuranpur. And he has done MBBS from GMC Nagpur, and his post graduation from Sambhajinagar, and DNB also he has done. And oculoplasty he has done from HV Desai Eye Hospital in Pune. We welcome you, sir. And as you know about our speakers, I'll just give a brief introduction. Dr. Gunjan Rathi, she is an excellent oculoplasty surgeon. Presently, she's practicing at Total Retina Eye Care Hospital at Nagpur. And also she is visiting, as I personally know her, she is my batchmate. She visits lots of places, all the renowned hospitals in Nagpur and Central India. Plus, she has done MBBS from GMC Nagpur, and she has done MS from Barodara Medical College, and done her oculoplasty from Arvind Eye Hospital, Madurai, and she has multiple presentations and papers to her name. And beyond her professional achievement, she is a fitness enthusiastic with a passion for exploring new places, cultures, and book. We welcome you, Dr. Gunjan. And our chief guest, Dr. Akshay Nair, sir. He is a renowned oculoplasty surgeon. He's an author. He's a clinical scientist who currently serves as a director of ophthalmic plastic surgery and ocular oncology at Mumbai. Throughout his career, he has achieved multiple awards, whether it is American Academy of Ophthalmology, Asia Pacific Academy of Ophthalmology. He has 130 indexed scientific papers and many chapters he has written in the book. And specifically in 2022, he was featured in the top 2% scientist list published by the Stanford University, as recognizing him as the most cited scientist globally. And he has multiple best paper awards, as we can see. And he's a member of the Oculoplasty Association of India and Asia Pacific Society of Ophthalmic Plastic Surgery and Reconstructive Surgery. We welcome you, sir. And our own Dr. Milind, sir. He is my senior. He is my mentor. I owe him, and I'm very grateful for sir. He's a very dedicated, experienced ophthalmologist, oculoplasty surgeon, and he's serving since 11 years in Nagpur, and he's presently practicing at Eye Sparsh Hospital in Pratapnagar at Nagpur. And I can say that he has taken the oculoplasty of Vidarbha and Nagpur to another level. He has done his MBBS from GMC Nagpur, and from AIMS Delhi he has done his PG and even SRship. And Dr. Sir's extensive experience and commitment to his patient, he is a trusted name in the field of oculoplasty and ophthalmology. We welcome you, sir. And I'll now escape, and I'd like speakers to start the presentation. I'll stop sharing
Yes.
my screen.
So Gunjan, can you start sharing your screen?
Yes, ma'am. Is it visible? Am I audible?
Yes, Gunjan, you can go ahead.
Yeah. So let me begin. Good morning, everyone. I am Dr. Gunjan Rathi. My topic for today is anesthesia in DCR surgery. So as we begin this topic, let us first discuss the elephant in the room. Most of you all are mainly cataract surgeons. And so, when you're doing cataract surgeries, it is mainly a painless surgery, a blood free surgery. You go in 5 minutes, come out. There are no stitches, there is no putty, nothing at all. So, cataract surgery and DCR surgery actually differ in this regard. And maybe that is the reason why the resistance and the fears about DCR, there is blood, there is pain, the duration of the surgery is higher, stitches are more. But then the good news is, if you give a proper anesthesia to the patient, half of these problems are taken care of even before you start the surgery. So once the patient is pain free, there is no anxiety, there is reduced bleeding, and because the hemodynamics are stable, and then you can go ahead with the surgery properly. So with this, let us begin whether general anesthesia is better or local anesthesia. So there have been multiple papers, as you can see. So these papers, they have a consensus that in case of endoscopic DCRs, general anesthesia is the gold standard. It is still better than local anesthesia and gives better results. But in case of external DCRs, very well it can be done under local anesthesia. In fact, there are some advantages to it, like there is reduced intraoperative bleeding, the inpatient stay and healthcare expenditure is lower. Also, in case of patients who are elderly and where comorbidities are there, where GA can constitute a risk to their life, local anesthesia comes to our rescue. So, in multiple ways, local anesthesia actually is better as compared to general anesthesia in in external DCRs. And also, the success rate of the surgery does not differ whether it's general or local. So, what we can conclude is pediatric patients, of course, need general anesthesia. So, there is no question. And endonasal DCRs, general anesthesia is better. But for all other cases, very easily you can go ahead with local anesthesia. My personal preference always is local anesthesia with a good sedation, and it takes care of almost all the cases. So, going in the details of local anesthesia, I would like to divide it under three headings. One is the skin infiltration, second, nasal packing, and the third is intraoperative anesthesia. Nasal packing is also very important. This we might not be knowing. So, skin infiltration, let us get into the details. Now, skin infiltration is generally given at around 4 places, targeting the 4 nerves. The injection that is advised is equal parts of lidocaine 2%, 0.5% bupivacaine. Some people like to use adrenaline, some don't. So even there are variations in the concentration of adrenaline. Some like to use 1 in 1 lakh dilution, 1 in 2 lakh dilution, 1 in 80,000 dilution. Multiple variations are available. Important thing to note is with the higher concentration of adrenaline, there is risk of tachycardia. So you should know how much of that you are infiltrating. My personal preference generally is around 8 to 10 cc of anesthesia. What I give is lignocaine 2% with adrenaline 1 in 2 lakh dilution. And along with that, I keep 1 in 1,000 adrenaline cotton pellets during the surgery in case if it is required, where bleeding is higher. Generally, this takes care of the situation. Now, nasal packing. Nasal packing, I have to mention there are two things. I mean, generally you have gauze pieces at your center, but ribbon gauze is something some people have, some people don't. There is an advantage of using ribbon gauze because this is a longer gauze piece. It goes deeper inside, closer to the ostium, where we are creating the ostium. The smaller gauze pieces will either remain superficially or you will have to put in multiple ones. So be careful when you're using that because we want to anesthetize the nasal mucosa when we are doing it. Gauze piece generally is soaked in 4% lignocaine with some amount of few drops of 0.5% xylometazoline, and that is good enough for nasal packing. The third one is the intraoperative anesthesia. So this can be given to the nasal mucosa once you have created the ostium. Around half cc to 1 cc is good enough. And this helps in reducing the pain, bleeding both during the surgery. So let us see what are the nerves that we are targeting. The first one is the infratrochlear nerve. The infratrochlear nerve, as you can see, it comes from the superomedial part of the orbit and comes out parallel to the superior border of the medial rectus muscle. This is supplying the medial part of the eyelid and the lateral part of nose. The second nerve that we talk about is the anterior ethmoidal nerve. It is a part of nasociliary nerve. It is coming along anteriorly in the nasal cavity, close to the superior part of the nasal cavity. Its branches supplies the anterior nasal cavity medially and laterally both. It ends as a terminal branch, the external nasal nerve. This nerve actually supplies the skin in between the two nasal bones and including the tip of the nose. The fourth nerve that we discuss over here is the infratrochlear nerve, infraorbital nerve. This nerve is coming out from the infraorbital foramen, and as you can see, it is here near the lower lid medially. So this is the part that it supplies, the lateral part of nose, and also the medial part of cheek and lip. Now, let us go in a little bit of details over here so I can explain you properly. Again, over the skull. So this is the supraorbital foramen. Here, from here, the supraorbital nerves, supratrochlear nerves come out, and from here comes out the infratrochlear nerve. So this is the location over the skin where you'll want to give the injection. Injection will maybe come like this on this location. Okay. Now let us talk about the infraorbital nerve. You can see the foramen over here. This is the infraorbital foramen from where the nerves are coming out. And this is the location over the skin also at the junction of the lateral 2/3, medial 1/3, where you'll want to inject. Generally, what we prefer doing is we inject parallel to it and facing towards the lacrimal sac. So the injection will come like this. The third injection is over here, over the nose, lateral part of nose. So this is the area over the anterior lacrimal crest where you will actually make your incision and begin your surgery. So this is the third spot where we give the injection. All right. And the fourth one is the injection where we are targeting the anterior ethmoidal nerves that I talked about. Now, this is in the medial compartment of the orbit. So the injection over here, now this is a little different than the other three because these three are superficial, around 2 cc of injection in all these spots, 2.5 cc generally is good enough. Over here, what you have to be careful about is you are going a little deeper. I preferably use a 2 cc syringe with 26 gauge needle so that I don't go extra deep. You have to protect the anterior ethmoidal artery. You have to protect the eyeball. So the direction should be this. And you are going transcaruncular and you're facing the bone, not the eyeball. Okay. So with this, these 4 injections that you have to give around 8 to 10 cc. That should be good enough. Now, what care you need to take? Now, first we discuss about the local anesthesia. First one was the anterior ethmoidal nerve block. Important things which I told you already, that you are going medially and you are using a 26 gauge needle. That makes it safer so that you do not pierce the eyeball or the artery, what we were talking about, the anterior ethmoidal artery. The second thing is you have to avoid intravascular injection, and you can do that by aspirating before you're giving the injections. So first you aspirate, you check there is no blood coming, and then you inject. Reason being, you are using adrenaline over here. There's a risk of tachycardia, arrhythmia, convulsions if higher doses are given. Always aspirate, check. If there is no blood, then you go ahead with the anesthesia. In case of general anesthesia, we need to be a little more careful. Reason being, there is blood trickling down the nasopharynx and there's a risk of aspiration. So, of course, your anesthetist will know all these things, but you also should be knowing why is it more serious as compared to other surgeries. So, a throat pack, a cuffed endotracheal tube, cuffed one would be better. Hypotensive anesthesia so that the bleeding is on the lower side. There is a very small risk that the nasal pack may descend down and block the airway, causing hypoxia. So that is one more thing. It happens rarely, but it does happen. So you need to be knowing that as well. Generally, even after giving general anesthesia, it is advised that you give local infiltration, and that is because it takes care of the postoperative pain. Now, a word on probing. Probing in case of children, sometimes because it's a small procedure, a lot of people are confused whether you should give GA, you should give sedation, LMA is good, or what is the ideal thing to do. You should always go ahead with GA because there is always a risk of aspiration. And in today's era, it is always better to be on the safer side. So yes, I would suggest GA and intubation. Then maybe your facilities have a good setup for cataract cases, but as I've told you, DCR cases need a little more attention as compared to the cataract ones. So in case if you have inadequate facility, please take care of those things in advance and then go ahead with the GA case in your setup for DCRs, right? So my take home messages: proper anesthesia is the first step to a successful DCR surgery. Local anesthesia with sedation and a good nasal packing will take care of almost all your cases, barring a few. And GA in DCR is more critical than in other surgeries, so you have to be a little more careful. That's it from my side. Thank you.
Thank you so much, Gunjan. It was very nice. and you finished it perfectly on time. So I'll now request Milind to kindly take over for his next talk.
Thank you, ma'am. Hello, good morning, everybody. My slides are visible.
Yes, Milind, they're visible.
Yes, sir. So, being a cataract surgeon, we don't like a patient to have a tears in his eye or her eye. So we always want a happy, non-watery eyes because it's one of the prolonged cause of the dropout of the patient through the OPD. So there are many. If we talk about nasolacrimal duct obstruction, which we are talking since last 3 weeks, so I will be talking about the tricky situation with nasolacrimal duct and the other problem associated with it, which require a different type of tackling. So first is the primary nasolacrimal duct obstruction with tricky situation. Other will be the punctal problem, then the canalicular block, and last will be the functional block. So, coming to the tricky situation, these are the common questions which generally people ask either me or other oculoplasty fellows. They are associated like this. The 56-year-old female has a recurrent swelling. This swelling subside with antibiotic. The patient won't bother, and then next time she come back with another swelling. So everyone knows that it's an acute dacryocystitis. One has to just differentiate it from the associated swelling from the sinuses, malignancy around the surrounding area, and sometimes the topical allergic caused by the topical medicines like brimonidine. Sometimes the associated radiation for a surrounding malignancy can give the picture like a acute dacryocystitis. So there are different stages of acute dacryocystitis. What we have to remember that we don't have to touch any of these cases for DCR per se. They require, so what they require and how we have to proceed. So, so my general perception is I start with a IV antibiotic, though it's a preceptal area, but as it's a collection and the sac is sometimes get closed by the pseudo wall formation around the canaliculus and sac junction. So IV antibiotic works well. I generally don't drain. Most of the time, patient it get burst by itself and help to heal. Uh, and the always question will be when to operate. So this is the mucosal stage where you can operate. This is the stage where the inflammation is there, but the infection component has gone down. So this is stage where you can give some amount of oral antibiotic along with the steroid. Once the inflammation is subside, I will always ask patient that to see for the tenderness around the lacrimal sac area. If there is no tenderness, the inflammation has not there, and that time one can always consider patient for a DCR surgery. The another tricky situation is this the same type of acute dacryocystitis in a children. Oh, it can be at 1 year of age, 6 months, or 1 month. So always remember if there is no sign of inflammation, it's a purely a mucosal or amniocele. The canalicular and sac junction is also blocked along with nasolacrimal duct obstruction. Sometimes it get infected and this the situation becomes tricky like the bilateral acute dacryocystitis and it get burst to form an uh, very ugly faces with so much of discharge. So how I generally proceed is as they are children. So preferably we always give a IV antibiotic. Generally, I don't drain unless it is a bilateral case. And of course, there is a question of when to do a syringing probing. So this is how I proceed. If it is bilateral, that IV antibiotic, drain the abscess, probing, and then IV antibiotic. If sac intact, you have to give a direct massage so that the canalicular and sac junction get open up, and this first is drained by the natural pathway of canaliculus. Once it get open up, then you can give a Kegler massage so that the nasolacrimal duct get open up. That's why the sac intact situation is very good, because sometimes it helps to avoid unnecessary probing, like in this case. But the sac is ruptured, then you have to give IV antibiotic and then syringing probing. Bilateral cases, there is no question. You have to drain it either endoscopically or externally. And later on, you can do a syringing probing. Preferably, I wait for 9 months for a syringing probing, give a good sac massage. But wherever there is a acute dacryocystitis and the episodes are recurrent, you have to intervene even before the 6 months. Pediatric DCR is nothing but the miniature form of the external DCR. But always remember, give at least one try of syringing probing if not done previously. The success rate are pretty good, and it has rise very much high after adequate use of the mitomycin C. Though I don't do canalicular intubation in such cases, but there is a sufficient role also placed in the literature. So the basic steps are same, just the incision is small. You can dissect out, you can get a good periosteum elevation, and you can make out that there is a pretty much good area to operate. And if you make a good ostium, the sac and the mucosal flap are sufficient to close it. So if you are good with external DCR in adult, the pediatric DCR is nothing but the one step ahead. Another situation which we generally encounter, especially in a post-cataract surgery, is a punctal blockage. The patient has a patent system when we do the syringing, and the patient is asymptomatic for 2 days, and then once again the watering starts. This type of situation where the puncta is obliterated or it is closed, it is better to give a snip procedure. But if it there is no papillae, or a papilla is there, papilla is there, but punctal opening is not at all visible. The trial of snip or Jones DCR, or one can do the chemodenervation of the lacrimal area. This is another tricky situation where you have swelling in the lacrimal punctal region. There is continued discharge flowing through the eyes, but we are doing syringing, and syringing is patent. So these are nothing but the cases of canaliculitis, which requires surgical curettage and debridement, either punctal smearing or canaloptomy involving the puncta. So these snip and this type of procedure we can have in the cadaveric workshop. So we'll be skipping the videos of this. Another very important situation which we generally encounter is the soft stop. So after syringing, the fluid is coming through the same puncta, and you can make out that there is a tissue drag along the soft tissue. So this is called as a canalicular block. Always check the upper canaliculus. If it is blocked, then we label it as a bicanalicular obstruction. We divide it into before 8 mm and after 8 mm. This is the canalicular trephine, which can be used to open the canaliculus, which it is nothing but the tocar with cannula with sharp end. Once it gives a free opening, we can do a syringing through the cannula itself. If it is patent, you can intubate it with the mini monoco stent. So canalicular block, another question people generally ask whether we can do a cataract surgery or not. The cataract surgery is pretty safe when there is a canalicular obstruction, upper and lower. It is not safe in the when there is a nasolacrimal duct obstruction, though the fluid is clear on syringing sometimes. So this is the mini monoco stent, which can be used for the cannulation of single canalicular. It is pretty long. You can cut short and pass through the area where there we suspect the obstruction by the soft stop. So this is small video about the trephination. So canalicular block, as I told you, generally divided into distal below the 8 mm and after 8 mm. 8 mm we can use the canalicular trephination, or sometimes nowadays many people use a chemodenervation of lacrimal gland. Jones DCR is not a popular choice nowadays, but it can be done by some modification, like but combined approach is better, where we do nasal endoscopy. So this is the case of trauma with more than 2 years with both canalicular upper and lower canalicular block. The MVR blade is passed and visualized through the nasal cavity. Here that is secondary acquired nasolacrimal duct obstruction, which can be infectious, inflammatory, neoplastic, traumatic, or mechanical. So this is Pando, which is always gives you good result, while this is secondary acquired nasolacrimal duct obstruction, which always give a headache. So you have to rule out. The most important is traumatic nasolacrimal duct obstruction, which can be present as acute dicrocystitis after after the 1.5 year of trauma or 6 months of the trauma, or can be a quiescent, which is Roplast positive. It require investigation in a form of CT-DCG or plain CT, so that we can make out the relation of sac with the bone, sac with any implant which is placed during the orbital surgery. Like in this case, the implant is obstructing the nasolacrimal duct. So you have to remove the implant, you have to make an opening. Then some inflammatory pathologies like sarcoidosis, vaginal granulomatosis, and radiation, where you have to do a thorough systemic examination of the patient, because it also help you to diagnose for the systemic illness. Post radiation changes, and of course one has to rule out the neoplastic etiology like primary tumor or secondary tumors. Like this case, the patient was having the swelling in the lacrimal area. The system was patent and patient was not at all symptomatic. So you can make out that this swelling has some amount of yellow color of discoloration over the skin. This is the case of dermoid, which require dermoid excision, not the DCR or any other type of sac surgeries. So secondary acquired nasolacrimal duct obstruction has to be considered while diagnosing primary nasolacrimal duct obstruction, where there is no cause for the nasolacrimal duct obstruction, because it may be the cause of the failure. Need prognosticate the case and help to diagnose the systemic diseases. So functional block we will be talking after Dr. Nair's discussion, so that we can have his view about it. Like the patient, these are blocks where the system is patent, the lead laxity is not there, and the puncta is adequately open. Dye disappearance test is negative. So the patient are generally symptomatic in the form of watering. Thank you. Thank you for the patience, Liz.
Thank you so much, Milind. If any questions, you can just put it up in the chat box so that they can be addressed after we hear Dr. Nair. And I request Akshay to kindly start with this presentation.
Thank you so much. Am I audible?
Yes, you are.
Both the talks were extremely good and thorough. And I'll try to keep this short, and surprisingly, a lot of relevant points that they have covered are things that I also have. So it's wonderful. So I think DCR, like we already know by now, with with this being the third talk, this is the gold standard for treating NLDO. Over the years, endoscopic, with more ophthalmologists doing endoscopic DCR, has comparable rates with external DCR ranging between 90 to 95%. It literally is our bread and butter. If you look around the globe, like this paper from Korea, nearly 20%, 1 in 5 surgeries done by oculoplastic surgeons is a DCR or a lacrimal surgery. So the amount, it's obvious that we will not only be treating primary, but also secondary cases of DCR. So it's important we equip ourselves knowledge-wise and skill-wise on terms of how to handle these kind of cases. So I'll tell about why does a DCR fail. And I think the most commonest reason is the ostium is inadequately sized. And I'll just briefly go over this video of how I like to create an ostium in a primary DCR. So there you see that's where the sac lies. That's the lacrimal sac fossa. The junction between the lacrimal bone and the frontal process of the maxilla is where I initiate the ostium. And then with serially larger sizes of punches, you create the ostium. So while creating the ostium, you have to be careful to preserve the mucosa behind. So the technique that I use is to push back the lacrimal sac and keep it away, push the mucosa inwards, engage the bone, twist and punch, such that you take small chunks and not too big chunks of bone that could cause a lot of bleeding and also obscure the visibility. So there you can see now the pink mucosa is coming into view. So serially, we keep enlarging the sizes of the punches so that we get an adequately sized ostium. How big an ostium is an adequate ostium? Well, I like really large ostia. So in this case, if you see, the ostium should extend in all 4 directions, superiorly about 5 millimeter above the common canalicus, anteriorly as much as possible to make sure that the bridge of the nose is preserved, inferiorly till the bony NLD is deroofed, and posteriorly till the air cells or the ethmoidal air cells are seen. And if this patch of nasal mucosa is exposed and your lacrimal sac mucosa is intact, then your DCR flaps will be absolutely adequate, and thereby you're avoiding how to deal with a failure of your own surgery. But knowing how to do a good primary DCR is not going to prevent you from seeing other people's or failures from surgeons that have surgeries done by others. So if we look at causes of failure based on prior surgical techniques, if you see, the most common cause is actually a mixture of multiple causes. But again, if you go from the bottom up, the next most single common cause is cicatricial lacrimal ostium scarring, which is why I prefer to show how to make a large ostium, followed by intranasal adhesions. And combined osteal scarring with intranasal adhesions would take care of almost 50% of all your all your DCR failure causes. Same is the case even in India. Here, this is a paper from LVPR which surgery presented. There again, 50% ostium cicatricial closure. Closure of the ostium because either the ostium was too small, or if it was too large, there was an aggressive scarring process that led to that being closed. How do you handle it? the first thing you do is to confirm that it is a failed lacrimal surgery. And I think Dr. Millen made a very good point. Functional block is something you need to rule out. Patients may come and tell you that they've had a DCR, but the watering is still there. That could still be a secondary functional block, which means the patient already had a patent lacrimal system. You've done a DCR, and there is still watering there. Assess the duration since DCR, and I'll come to that a little later, and then break the news gently. Remember, it could always be your failed case that is going to a second surgeon, and you would want that patient to be told about how the surgery happened and what is the outcome, just like it would be your case. So you don't want to go and tell things like something on the lines of bad mouthing a colleague. Let them know that, see, this surgery has limitations. There is a success rate. Unfortunately, you landed up in being a small subset of patients in whom this has failed. We can correct this and give them the empathy and assurance that this can be corrected. And then they will, they would definitely buy into the idea of the need for a surgery. Always do an endoscopy. I understand not all of us will have an endoscope available with us in the clinic. If you can, you can even reach out to an ENT surgeon and ask them to put an endoscope up and let you know what is exactly the cause for the failure. So you know whether it's a deviated nasal septum, intranasal adhesions, in which case you can request them if they can do something about it. If it's a small ostium, or cicatricial closure of the ostium, then you can do it yourself, and then you can explain the need for surgery. Now, sometimes you have a failed DCR within a couple of weeks of surgery. And in these cases, you need to do an endoscopy and debride the ostium with a little bit of local triamcinolone injection such that the granulation reduces and the patency comes back. However, if it is beyond 2 weeks, then I would call it a late failure, and I would wait for at least 3 to 4 months before going in and operating again. So these are endoscopic pictures of what could go wrong after a DCR that causes failure. On the leftmost at the top, you can see there is a clear adhesion between the septum and the ostial site, and the ostium is completely obliterated. Here in the middle, you can see there's a tube coming out, but again, the ostial site is scarred. And in the third case, there is a fluorescein coming in only after injection, which means that there's probably a very small ostium which is not functioning. Now this is a case of doing an endoscopy in a case, and you can see right at the top, there is a clear adhesion between the ostial site and the nasal septum. And even if you come further back, you can see that the nasal septal adhesions are the reason why this case has failed. Going back to the first talk, I think general anesthesia is always better for revision cases, or at least giving sedation. If there is local scarring, the local anesthesia uptake is going to be suboptimal, which is why general anesthesia is needed. I always give tranexamic acid 1 hour before surgeries, and it really helps in reducing the bleeding. Keep stents and mitomycin C on standby so that in case you need to use them, you can use them. And I'll quickly come to a case of a revision DCR. So the most important thing is to use the previous incision. You don't want to leave another scar on the patient's face. Now remember, under the skin incision, you will find a lot of adhesion. Rather than using a cautery, use the sterile scissor to splay open the scarred fibers. And immediately after dissection of the scar, you would reach the site of the ostium and scarring. So here what I'm doing is using the tip of my instrument to palpate and see the extent of the ostium or the previously made ostium. And then I go beyond the site of the previously made ostium to expose some more bone. That way you know where the previous ostium ended. You can go adjacent to it to expose healthy bone and then start creating your new ostium. Be very patient and dissect carefully like you were opening conjunctiva with the scissors. And once you gradually do it, you will come upon the bone. Now here you can see that that's the bone on top, and underneath that, here you see the mucosal flap going underneath the bony ostium. You can see the previous ostium and the flaps over there. So now what we need to do is open up all the bone that is superior to the previous ostium. So now here we are putting in a punch, engaging that bone and excising the bone to expose more mucosa. The key is to enlarge the previous ostium and expose more healthy mucosa to be able to make the new ostium. These cases will bleed, so have a good suction machine on standby. So once you've created, exposed all the, removed all the bone, now here also you can see that the bone in front of the common canaliculus was left intact, which basically means that it's an inadequately sized osteum. So now once the osteotomy is done, I'm making an incision on the scarred flap. So this is the scarred flap from previous surgery, and I'm opening the flaps such that we are able to mobilize lacrimal mucosa on top, as well as the small sac flaps. In revision cases, getting adequate lacrimal sac flap may not be enough, may not be available. So you have to make sure you get good nasal mucosal flaps. Here you can see that the nasal mucosal flap is really big. It can stretch over, and then you can open up the sac or the remnants of the sac to create the sac flaps, which are then sutured together. Adjuvants, namely mitomycin C and stents, something that I'll come to in a bit, and explain why we may need to use them to improve the success rates. So here we are able to mobilize adequate amount of sac. I've used the stent, and then I'm going to suture the flaps. So this is how a revision case can be handled, especially in a case like this where the osteum was scarred and we had to dissect out more bone surrounding it to create the mucosal anastomosis with the flap. Now, intubation. Now, this is a review of why should we intubate or put a silicone tube. And most authors are of the opinion that cases where there have been repeated episodes of dacryocystitis, which means that the sac is scarred and small, or cases where you're not able to get good flap creation or revision surgeries, it is a good idea to put in a tube. And when we look at mitomycin C, now we know a lot of authors use mitomycin C, some people don't, but what is the correct dosage that we need to use? What is the correct indication of mitomycin C? This is a table with all the papers that have reported outcomes with mitomycin C. And you can see that it ranges from 70% to 97%. So it's all over the place. And again, if you see on the second column, which is concentration of MMC, some authors using 0.4, 0.5, 0.2, 0.1, 0.05. So authors have reported multiple success rates with different varying concentration. So what is the ideal concentration to be used? Well, this was a paper by Dr. Javed Ali, where they actually studied the effect of different concentrations of mitomycin C on the human nasal mucosal fibroblasts. And they reported that the concentration of 0.2 ml per mg per ml for 3 minutes is adequate to reduce the growth of these fibroblasts without causing apoptosis or cell death. So you don't want to cause necrosis of the cells, you just want to inhibit the scar family. So 0.2 mg per ml for 3 minutes is adequate. So to summarize, ideal primary patient selection is important because, like Dr. Milind said, you don't want to choose a patient with a canalicular obstruction or a common canalicular block for a DCR. You would rather try other ways like definition or a CDCR or Jones tube or lacrimal gland Botox. So those patients are already, they have a reduced chance of a success surgery if you do a DCR. Counsel the patient once they come to you and you have diagnosed that the previous lacrimal surgery has failed. Let them know what could be the possible causes, what happened, explain the plan, and then go ahead with surgery. Adjuvants like mitomycin C and bicanalicular intubation are very useful in improving success rates. And there is nothing like a sound technique in primary surgery to prevent your own primary DCRs from failing. Thank you.
Thank you so much, Akshay. Are there any questions regarding any of the talks? You can unmute yourself or you can put it in the chat box.
I can ask one question to Dr. Akshay.
Yes.
Sir, how you proceed in functional block after DCR or a primary functional block?
Yeah. So my preferred technique is to refer the patient to someone whom I don't like. No, we're just joking. Yeah, functional DCR is extremely difficult to treat because So, just for the benefit of the audience, functional DCR is when a patient comes to you with epiphora and you do an irrigation and the lacrimal sac is patent. So, basically, they have a patent NLD, but they are complaining of watering. Or you've done a DCR and you do an irrigation, it is freely patent, but they keep coming complaining of watering. So, first thing I like to check is to make sure that there is no ocular surface cause that is causing this, which could be either meibomitis, blepharitis, or any surface-related issue. One of the common causes that I've also seen in slightly elderly patients is conjunctivochalasis. Then there is this layer of conjunctiva that comes and sits on top of the punctum. And when we do irrigation, we look at the lid, so we don't end up seeing that. And when we irrigate, then it's patent. So just ruling out all of those things. And they need a lot of hand holding. And nowadays, if it's a primary functional NLD, I make sure that none of these coexisting causes are there. And then if they are open to an option of DCR, I offer that. Or else I decide that they are really primary hyperlacrimation cases and I offer them lacrimal gland Botox. I'm actually also interested to know how you deal with these patients. What is your strategy?
Yeah, same, sir. Sir, another question generally people ask, like phakomorphic glaucoma with nasolacrimal duct obstruction.
So what do you do
How
if you
to
have
proceed?
like an emergency case and you have to do something?
Yeah.
Yeah, so that's a great question. So there's this one paper by Kashkoli who what he did was he looked at the change in the conjunctiva flora after a DCR. And they suggested that the conjunctiva flora comes back to the normal state only 4 weeks after the DCR surgery. So if you were to do a DCR and then tell your cataract colleague or you do the cataract surgery the next day, the conjunctiva, cul-de-sac, the organisms really haven't changed. You can add antibiotics, but that hasn't changed. So then the same thing is even for a DCT. That nothing really changes in that. So ideally, you would want to wait 4 weeks. But like you said, if it's an emergency, you can do a DCR and then go and there is no benefit of doing a DCR versus a DCT. Remember, if you do a DCT, the patient is going to land up with watering for the rest of their life. So I think unless the patient is absolutely moribund and bilateral total cataracts and one of those patients with poor compliances, I would never advise a DCT.
Thank you. One question from the Priyanka. Till what age we can do a massage, clinical massage in pediatric age? What is your take, sir?
Sorry, I was muted.
Yeah.
I'm a little more generous. You mentioned 9 months. I allow till about 15 months. But at the first visit, I always tell them that massage works till 12 months. And beyond that, we need to grow. Then, ask them to continue massaging. That also helps you buy some time. And they also assimilate the idea that, yes, I will need to do probing. Because the outcomes between 12 months and 15 months really doesn't change. So I wait till normally till about 15 months. Anything beyond 18 months is pointless in doing any massaging. Always probing within any child who presents after 18 months.
There is another question. What is the minimum time we should keep the stent? Either mini monoco stent or bicanalicular stent. So, sir.
So I think that's questions for you.
Yeah, it's actually for you.
Actually, if there is a canalicular block where I am doing canalicular trephine, I generally keep it for 2 months at least because before 5 to 6 week, I was finding out that there is a recurrence rate too much. And if it is case of failed DCR or traumatic DCR where I am putting a bicanalicular stent, I generally prefer to keep it for at least 2 months. So my duration is 2 months. which I generally prefer. Look for the granulomas around the area or any active discharge. If it is not there, most of the time the silicone is very good material. If it is not there, we can keep it for 2 months. But in traumatic cases, you can take it out early also, where you repair the canalicular block. Dr. Akshay, can you?
Yeah, well, I think what you said is correct. For canalicular blocks, I keep it for 6 to 8 weeks. I am a little more scared in cases of secondary NLDs or canalicular obstructions where I've done a DCR. In those cases, I actually end up keeping it for a little longer, up to 6 months. Of course, intermittently, I actually do irrigation from the side of the tube just to make sure that the ostium is patent. And then I do it. Yeah, but just, scientifically, there's something known as a biofilm phenomenon, which is a thin layer of deposits, which can be a source of bacterial infection. And the biofilms can form as early as 4 weeks after the surgery. So ideally, the patient is better off taking off the stent between 4 to 6 weeks. But I don't think I am confident enough to do it at that early stage. 4 weeks is too less for me.
How much duration you give after acute diagnosis studies to take a case for endoscopic or external DCR?
No, I think, like you said, just to make sure that externally there is no induration or no fistula and there is no gross tenderness. Once that's settled down, I think if some patients, reach that stage within 10 days, some patients take 1 month. So, but only thing I do is keep them on topical drops such that it prevents the formation of a recurrent abscess. You don't want one episode to go and then the patient comes back in 2 weeks with another episode.
Yeah.
Sir, I have few questions.
Yeah, Preeti, go
You
ahead.
can continue, sir. Sir, if a patient with partial nasolacrimal duct obstruction comes, like some amount is going inside, some is coming out. So, what about cataract surgery? When people ask the cataract surgery, before that, you advise something, or what should be done?
So, I'm a little unconvinced on the concept of partial NLD because there is either NLD or there is no NLD. If water comes through, then there is no NLD. We need to understand that our rate of irrigation when we are checking is very fast. We are taking a 2 cc syringe of saline and emptying it within 2 seconds, which is a flow rate of almost 1 ml per second. And the rate of actual NLD going down the throat from the nose into the mouth or into from the NLD into the nose is 0.1 ml per minute. So the ostium or the opening of the NLD is meant to be that small. So it's not, the diameter is not big enough to support the flow of the force that we are using. So I'd repeat the irrigation very slowly and confirm that comes in the throat. If it comes in the throat, but the patient is still complaining of watering, I would treat it as functional epiphora. But to answer your question, if even 1 drop of water comes in their throat, I would have absolutely no problem in telling the cataract surgeon to go ahead with cataract.
Okay, sir. Sir, I have seen that for main reason for failing in my cases of DCR is when there is excessive bleeding. It can be I make a good ostium. Still, if more amount of bleeding is there, there is more chance of failure, I suppose. And what we used to do in Arvind, we'll take a probe. Like a Bowman's probe, and if in early first week or within first 2 weeks we are feeling, we just probe that ostium area, and many of the patient would not come with watering later. Means that simple probing with a larger probe, 2-3 probes. Then what is your view about this?
Yeah, I think that's similar to what I mentioned. See, when there's going to be blood or blood product
Granuloma.
that is going to incite inflammation, that is going to incite a granuloma. So it's the same thing whether you do it with a probe to dislodge any loose tissue or whether you go endoscopically and with an alligator forceps actually take out
remove the granulomas
and a little steroid injection around the mucosal edge.
Okay, through endoscope only. Okay. And one thing more, sir. MMC, you in every pediatric patient, MMC should be used. What is your view? It's not.
So in children, I don't use it.
You don't use.
Children, I may be okay.
Sir, also you use MMC in
Yeah.
all
In
pediatric
all
patients?
pediatric cases, I use MMC. I don't use
And that's-
intubation actually. Yeah.
So there are
Sorry.
different opinions. But
Yeah.
at the end of
Yeah.
the day, we are still able to manage and get the success. So
Because I have not used MMC in pediatric. I don't use stent also. A bigger ostium, that's it. That was I was asking if MMC is to be used. It's okay.
You are pretty now.
I think
You can do
yeah.
whatever.
Absolutely. As long
Yeah.
as the osteum is good enough and the
Yeah.
mucosal edges are
No
using.
use.
So, Akshay, do you use MMC in all adult DCRs?
Yes, MMC in all adult DCR, but no tubes in adult DCR. In pediatrics, no MMC, but we usually use.
One more question, sir. Should we use MMC in cases with multiple episodes of acute diagnosis?
So that depends on how big your flaps are. If you think your mucosal flap, your lacrimal sac flap is very small, and you will not, it's not adequate enough to hold up the edge of the nasal mucosal sac, then you may. But see, the concept, why are we using MMC? We are using MMC to prevent this nasal fibroblast from the edges of the ostium to grow towards the ostium and close it. In acute dacryocystitis, the lacrimal sac flap is going to be small. The nasal mucosa is not going to be damaged. So MMC is where two things. One is where, you've had a previous case of a failure and you know that this patient has a tendency for the fibroblast to grow. There you use it, or you are unsure of your nasal osteal size, you think it's small and you want to preserve it, that's when you can use MMC. Intubation is where you want to make sure that the canalicular passage and the lacrimal sac opening is not going to close. So in acute dacryocystitis, I would rather use a tube rather than an.
I have two questions, sir, for you. One is like after a prolonged intubation, sometimes it happens that you see a granuloma at that place after removing the stent. How do you deal with those granulomas?
So you can either remove it, or I'm now very liberal with local tricot injections.
Okay.
So endoscopically, just inject 0.1 cc at the base of the granule.
Okay. And the amount of injection that you will give at that site, 0.5 cc,
0.1 cc. 0.1
cc is good enough.
So use a 1 cc syringe and a 24 gauge IV cannula needle on top of that. You can reach it up right there and inject. Or if you are in a multi-specialty, you will get spinal anesthesia needles also. You can go right up there.
Okay. And what is your experience with the lacrimal gland Botox, like the dosage that you give and how the results have been for you?
We've had very good outcomes with lacrimal gland Botox. So 2.5 to 5 units, depending on how severe the watering is. I prefer only 2.5 units. I don't like to put 5 units or more. If I can just share my screen. So we even published these results in functional and non-functional Botox. So usually, again, I think we have this is our technique. Most of the patients, the mean injection was 2.5 units. We had 7 in the functional and 24 in the non-functional. Most of them had, at 3 months, they were much better than what it was earlier. So basically, the assessment was using the Monk score. Monk score is the severity of watering. Pre-injection, most of the patients in the functional group had a Monk score of 4, which means constantly having to wipe their eyes. Post-injection, their Monk score at 1 month was 1. So definitely, you get a good reduction in the amount of epiphora that day.
Okay. What about the repeat injection? What is the duration generally it works for? What have in your
3 months. 3 months.
Okay.
But if we do a needling, some type of fibrosis can establish, and this can last for the longer time also.
True.
Yeah.
Because by needling, you're destroying more acini and inducing scarring. So while you're injecting, you can do multiple passes in the lacrimal gland and then inject at any one spot. And anecdotally, that helps to is the duration for which the watering stops. Very true.
Akshay, I have one question. Out of the two, the endoscopic as well as an external, which one are you doing more now?
So primary endoscopic, for revision external.
Hello?
Yeah. He
Yeah,
was
I think
saying for primary, he is using endoscopic, and for
Acha.
the secondary, for revision cases, it's the external one.
Actually, for revision, all external.
All external.
I'm not comfortable with revision endoscopic because the anatomy is very distorted. For primary, I leave it to the patient. So actually, I'd say a mix of 50-50.
Okay. So, any more questions, anyone?
Yeah, Dr. Bhaiti has many questions. So we already discussed with dicrocystatitis with and its management. She also want to ask about the management of atonic sac.
So, the atonic sac, I think it just needs a simple DCR. In atonic sac, the DCR are very easy because sac is usually much larger. So, like a plain DCR without intubation or any such thing, you'll be able to do that.
So Dr. Nair will be there on the next Sunday with us. We can ask many questions, and he will be demonstrating his surgical skill on the cadaver, and also will be there with his many tips and tricks for doing a primary external DCR. So now we can stop the discussion and ask the
Dr. Mili,
panelists.
one question.
Yeah, sir.
Yeah. To ask why Dr. Akshay prefers endoscopic DCR over external.
Yeah. So I know that's a valid question. It's just that I've been trained in endoscopic DCR, and even Dr. Richa here, she's also done a lot of endoscopic DCRs. And over time, you get comfortable with that technique, and you avoid the scar and the problems that you have of bleeding, etc. Suture removal are not there. But on the flip side, yes, patient needs sedation, patient needs GA. So it's just that over time, comfortable, and patients also now, if they come to me saying, no, I don't want a scar or anything, then we can tell them. An external DCR is always a surgery, and an endoscopic DCR you can get away by telling it's a procedure. We are putting a endoscope and just opening that, ostium. We are not taking any stitches, so that's patients somehow mentally find that easier to bind. At the end of the day, I think it's a patient preference. I give both options, and they choose.
Okay. So, as a general ophthalmologist, when we want to learn a DCR surgery, what you suggest? Shall we go for endoscopic?
All endoscopic surgeons have to be thoroughly, at ease with the external route first, unless you're an ENT. But yes,
Okay.
External
very stiff curve.
Got your point. Yeah, got your point. Thank you.
So if there are no more questions, I request Milind to thank everyone and request them to join us again on 25th.
Yeah, everybody, thank you, Dr. Mukadam sir, Dr. Patil sir, and Dr. Shivani ma'am for your wonderful guidance for this all talk. Dr. Nair, thank you for excellent talk and patiently listening our questions and answering them. Dr. Preeti for kind introduction of all speakers and to start the session, and Gunjan for lovely talk on the and clearing the doubts about the blocks. So we'll be meeting on the next Sunday morning. The breakfast and lunch will be there, and so much of tips and tricks from the Nair.
Thank you. See you all on 25th. Bye-bye.
Yeah.
Akshay, thank you.
Thank you, Patil sir. Yeah.
Thank you.
Thank you.